As part of the initiatives following from the Michael G. DeGroote Center for Medicinal Cannabis Research, and just on the screen you see my co-director, James McKillop, and also our medical director, Ramesh Zacharias. The key areas of focus for our institute are threefold. One, to curate evidence-based content. This will take place in a number of different formats: research summaries of publications, short evidence briefs, more expansive knowledge syntheses, and we've also partnered with the Health Information Research Unit at McMaster University to create a portal which will deliver high-impact, newsworthy research papers relevant to the topic of medicinal cannabis. We are also focusing on a number of primary research areas ourselves, in particular the role of medicinal cannabis in either chronic pain or mental health complaints. We are also very keen to explore the unintended effects of medicinal cannabis, with particular focus on cannabis use disorder. We've also brought on expertise such that we can focus on economic evaluations, policy issues, and basic science work. And our third area of focus is to create a network of individuals interested in research and policy around medicinal cannabis. And we have our inaugural conference coming up on February 9th and 10th of 2018, registration of which will be open soon. We have a number of research projects that are underway. We have a systematic review looking at the role of medicinal cannabis for chronic non-cancer pain. We are also embarking on a pilot study to look at the feasibility of a larger trial exploring the use of medicinal cannabis to reduce or persistent pain after the procedure. We are embarking on a series of interviews to explore patient perspectives around the role of cannabinoids for pain management. There is some stigma associated with this particular agent. There's a number of ways in which it can be imbibed, and we're doing work to better understand the interest of patients in engaging in research to explore the effectiveness of medicinal cannabis. We're also pursuing basic science research whereby we are introducing neuropathic lesions in animal models and exploring the role of medicinal cannabis to elucidate the mechanism of action at a cellular level. In terms of more details on these projects, if there's interest, I'd be happy to correspond by email about any of them, and my email address is provided below there. Regarding our work in the areas of addiction, we are looking at an observational study to establish trajectories of cannabis misuse in emerging adults. Another project is focused on understanding reward, value, and motivation in individuals with a diagnosis of cannabis use disorder. A systematic review focusing on treatment of cannabis misuse, particularly in younger adults, as well as a study looking at the efficacy and mechanisms of medicinal cannabis as a treatment for symptoms of anxiety. If there is an interest in further details on any of these projects, my co-director, James McKillop, would be happy to oblige, and his email address is presented at the bottom of the box there. Finally, one of the projects I'd like to highlight is a medicinal cannabis registry. We have a large chronic pain clinic at McMaster University, and we will be using the registry to capture demographic and social characteristics of patients prescribed medicinal cannabis, monitor trends in clinical outcomes, and identify factors that are associated with elevated risk of adverse events. Once the registry has proven to be robust in terms of our ability to collect the data, we will look to expand the registry to other academic pain centers in Canada. And again, for those parties interested in hearing more about this, our medical advisor, Ramesh Zacharias, would be happy to provide those details. and his email is provided at the bottom of the screen. Regarding issues related to policy and content, prescription of medicinal cannabis has been legal in Canada since 2001, at least for certain medical conditions. However, despite the fact it was prohibited for use otherwise, a study conducted in 2013 found that Canada had the auspicious honor of having the highest rate of marijuana use amongst youth versus all other developed nations. Cannabis is also the most trafficked drug in the world. In Canada alone, the annual revenues anticipated to be derived from illegal sale of cannabis is on the order of about $7 billion. And in response to some of the challenges with pursuing prohibition as a strategy to deal with cannabis, the federal government has made a commitment to legalize recreational use as of July 2018. Recent surveys indicate over 4 million Canadians have used cannabis at least once, but this is currently an unregulated market, and so there's concerns regarding the safety of use of this product. There's also increasing questions as to whether the current policy of prohibition represents optimal use of scarce government resources. Prosecution and enforcement of cannabis laws is resource intensive, and clearly the available data suggests that prohibition has not been an effective campaign. Now, in 2014, the marijuana for medical purposes regulations went into effect, and the government began to maintain a public database of all licensed producer. And patients who receive a medicinal cannabis prescription from their physician must obtain authorization to possess from Health Canada and register with an order from a licensed producer. So there's increasing regulations trying to guard practices around this particular modality. Now, as of 2015, the definition of medicinal cannabis expanded to include any form of the substance. So not only simply smoked cannabis, but also edibles, teas, and oils. There's a wide assortment of ways in which it can be intaken. However, the dispensaries that are available providing these products often have variable and changing product available. And one of the key challenges is that even if patients receive a prescription for medicinal cannabis with certain parameters, for example, a certain content of THC or CBD, which are thought to be the main therapeutic agents of cannabis, the licensed producer they go to may not have a product in stock that actually meets those specifications. And if they do, they may not have it the next time the patient comes for a refill of their product. So there is increasing regulation, but also problems in terms of dispensing the products that are being prescribed for patients. Now, the focus of the work that I'm going to be talking about today is examining the impact of decriminalizing or legalizing cannabis, which is particularly topical given the fact that Canada is going to embark on this experiment in about a year's time. And the literature synthesis that was undertaken identified 43 documents to inform this issue. That includes 5 systematic reviews, 6 non-systematic reviews, a program evaluation, and 31 primary studies. The endeavor also included a scan of the current legislation in 35 jurisdictions that have or are in the process of legalizing or decriminalizing cannabis. So there is some evidence from which to learn about the implications of these policy issues. So the first insight revolves around whether or not legalizing or decriminalizing cannabis leads to increased use. And there are 2 systematic reviews on this topic which found no evidence for increased use after legalization or decriminalization of cannabis. Now, there was a primary study done that did find an initial increase in adolescent use following decriminalization, but this was a short-term effect. And once the study continued to follow the population out to 5 years, there really was no discernible increase in rates of use as compared to before cannabis was decriminalized. So the evidence, at least that we have to date, suggests that while there might be a short-term uptick in use, that increase does not appear to persist. Insight number 2, there is evidence from one systematic review that cannabis use does increase risk of psychotic symptoms. And I presented the adjusted odds ratio from the pooling that they did there. And the association that they found was stronger amongst younger consumers. Particularly, they looked at individuals that began use at age 15 versus those that began use at age 18. Both showed an association, but it was quite a bit stronger for for younger users. And I should also note, however, that a causal effect has not been established. So it appears as if individuals that are already predisposed towards developing a psychotic disorder simply experience an earlier onset of symptoms than they would otherwise. So we don't really have evidence to show that cannabis can cause psychosis, but it does appear to trigger an earlier expression of psychotic symptoms in those that have a predisposition to developing a psychotic disorder. There's also some evidence that shows an association with increased depressive symptoms. However, as with psychosis, a causal relationship between cannabis and depression has not been established. We have an association, however. Now, I mentioned in the previous slide that we are concerned about the age at which users are first exposed to cannabis. And we have at least some evidence to suggest that age of first use is related more to access of the product and not legalization. There's limited data for this, but we do have one observational study from the Czech Republic, which did not find any decrease in the age of first use when cannabis was decriminalized. The Netherlands, a study from there, used a little bit more of a sophisticated design. They looked at 2 factors to explain the age at which users began. One was whether or not it was made legal. That did not seem to have an impact. However, the proximity of youth to a dispenser did appear to be a significant factor in encouraging earlier use. So clearly this is a modifiable issue to make availability more difficult for young users. And again, at least the limited evidence we have suggests that decriminalizing of cannabis does not appear to lead to earlier age of first use. Fourth insight we looked at from the literature was quite interesting. There appears to at least be an association that in jurisdictions where the use of cannabis has been allowed for therapeutic purposes, there have been lower rates of suicide. In particular, one primary study found that this reduction was greatest amongst men aged 20 through 39. You can see a graph there from this paper. The blue line indicates jurisdictions where medicinal cannabis was allowed, the red where it was disallowed. And you can see that there does appear to at least be an association with some reduced rates of suicide. Again, we don't know if the effect is causal, but it does represent an interesting trend. We also see in jurisdictions where prescription cannabis use has been permitted, there have been significant reductions in the use of prescription drugs that are typically used to manage conditions in which preliminary evidence suggests medicinal cannabis may have a role. These include anxiety disorders, depression, nausea, pain, sleep disorders, and muscle spasticity. And it suggests the possibility that when medicinal cannabis is made available, that users in some cases may be substituting for prescription medication, which would suggest that they may be deriving benefit from use of cannabis that allows them to not rely on their prescription medication. Again, we don't know if this is if this demonstrates a true effect or simply an association, but it is an interesting trend. We are all aware, I think, of the tremendous increase in opioid-related mortality that has affected, in particular, North America. Opioids are commonly prescribed for chronic pain, an area where there's at least some evidence that cannabis may have a therapeutic effect. And there was an interesting study reported in the journal of the American Medical Association showing an association with a reduction in opioid-related deaths in states that permitted use of medical marijuana. And it appears as if this association became stronger over time. In particular, in the first year after medicinal cannabis had been legally permitted, rates of opioid mortality, opioid-related mortality, decreased by about 19%. However, after 6 years following legalization, there was an overall 33% reduction from baseline. So again, an interesting trend suggesting that some patients dealing with chronic pain, for example, may be choosing to substitute their opioids for cannabis, and there is obviously a much lower risk of mortality associated with cannabis versus opioids. Another insight that came from the work is that once cannabis becomes legal, there becomes a preference for alternative forms versus simply smoked. For example, vaporizers or edible products. And we need more information to understand the impact of this increased choice and selection of different methods of consumption, such that policymakers can establish effective manufacturing and labeling regulations. Just to give you one example of a potential implication of this, the traditional form of intaking cannabis through smoking allows for much quicker effects. The peak blood levels occur within minutes of consumption. However, if you ingest cannabis, it takes quite a few hours before there's an effect noticed. This has a potential issue in the sense that individuals who do not notice an effect may continue to consume something in edible form, putting them at a higher risk of an overdose versus those individuals that are smoking and getting a much quicker effect. So again, an interesting observation, and one that probably has important implications for both safety and policy issues. The eighth insight that we derived from this work was that legalization of cannabis appears to be associated with a reduction in alcohol use. Again, we're seeing somewhat of a substitution effect. And this has been shown by reduction in per capita beer sales in places where cannabis has become legal, a decrease in total alcohol consumption, reduction in heavy drinking, particularly amongst youth, and most impressively, although it is still an association, a 13% absolute reduction in fatalities involving alcohol. These tend to be motor vehicle fatalities. Now, I should also state, however, that there's been an association for an increase in traffic fatalities where individuals tested positive for cannabis. But the study that found this was unable to provide any details on whether or not individuals that tested positive for cannabis were at fault for the accident or whether they were intoxicated at the time of the accident. So again, more evidence along with the prescription drugs for a substitution with alcohol, uncertain as to whether or not that leads to reduction in overall harm or not, but it remains a possibility. There's also evidence that price points influence purchase of legal cannabis. As I mentioned before, there is a significant black market providing illicit cannabis, and a number of countries that have explored this issue have been aware of this. And so what they've chosen to do, for example, in Uruguay, is they purposely set the price of obtaining cannabis to be competitive with the black market. They wanted to ensure there was sufficient incentive for patients that were using this product either for medicinal or recreational use, that they would be encouraged to go through legitimate pathways where safety and regulation had been overseen versus the black market. They also employed an excise tax on cannabis for recreational use, and they were very careful to ensure that advertising around cannabis was done in such a way as to avoid exposing children to the messaging. Now, not every jurisdiction appears to have completely gone in this direction, and I saw on CNN yesterday they've come out with a report suggesting that in California, which has had legalized medical marijuana since 1996, and they are pursuing legalization of recreational marijuana as of January 2018, they are considering a tax on marijuana by as much as 45%. And the authors of this report indicated that putting it at such a high price point would be unlikely to deter a number of current users from moving away from the black market. So certainly setting the price point appears to be a critical consideration, encouraging users to move towards a regulated system. Finally, there has been a great deal of concern regarding the challenges around prohibition of cannabis. It's extremely costly, all the legal enforcement that has to happen, the prosecution, not to mention the impact of having criminal charges on one's records. And at least in Australia, when they moved towards a legalization of cannabis model, they found that they actually were saving money overall. The money that they saved on legal enforcement was not entirely made available for other purposes. They did dedicate funding, for example, towards education and information and prevention services, but overall there was a substantial net increase in the revenue available for the government to put into other areas. So it does seem as if there are potentially socioeconomic benefits to the legalization of cannabis. In conclusion, there's been some important insights from the work that's been done looking at the experiences of other jurisdictions with the legalization or decriminalization of cannabis. And the basic sense from the work is that prohibition of cannabis has largely been unsuccessful in a number of jurisdictions, and because of this, there's been an increase in terms of decriminalizing or even legalizing. There's also been awareness that individuals, at least in some cases, appear to be using it for therapeutic benefits, and there's an interest in trying to study the effects of medicinal cannabis. And clearly, when a controlled substance is illegal, research becomes all but impossible to do. This is important in the sense that compared to other controlled substances, cannabis has undergone very limited scientific research. We don't have a lot to go on. We know that cannabis is associated with both benefits and harms, but the role of medicinal cannabis and for which condition it might help has not yet been clearly established. So decriminalization and legalization will certainly help facilitate research to answer these important questions. And finally, the impact of legalizing cannabis in other jurisdictions has important lessons for the experiment that we are currently undertaking in Canada, and the information that we've gleaned from looking at the results of their either legalization or decriminalization should be considered when making policy here in Canada. And finally, as I've mentioned, we are embarking on a large initiative here at McMaster through the Medicinal Cannabis Research Center. There is a website available where you can see what kind of projects that we're undertaking, get more information on the forum we have coming up in February, as well as other opportunities to participate. And the website for that, the address for that website is on the slide you currently see. Thank you so much for your time.
Thanks, Jason, for those great insights. That's excellent. I'll just pass the presentation over to Kerry to add in some discussion and comments from her experience and her perspective to add on to that before we go to the Q&A.
Great. Thank you, Stephen. Thank you, Jason. I would like to start by reiterating Jason's point about the lack of evidence on cannabis generally. While there's been relatively more work done on establishing the evidence base for the health effects and epidemiological effects of cannabis, there really is a lack of robust evidence base talking about what the effects of legalization and even decriminalization are on a population level, which makes this an incredible challenge for Canadian policymakers to be embarking on such a new route without much evidence to go on. Part of the reason for this may be a lack of jurisdictions that have undertaken this. That said, there's been big pushes, particularly in the U.S., from early adopters like Colorado and Washington to put out findings. So we may see these come to light as they roll into kind of their third and fifth year of implementation. The exciting turn on this is that it means, as Jason mentioned, that Canadian researchers are going to play a pretty big role in documenting the experiences across provinces and territories over the next few years and determining and establishing kind of a strong evidence base in this area for other countries to potentially learn from. In terms of the work at the Health Forum, we've undertaken 2 rapid syntheses, one of which was conducted by 2 previous Forum fellows and the assistant director of the Forum on the impacts of cannabis legalization on youth and responses that can be taken by public institutions. And the other was conducted with Jason's group on the broader subject of decriminalizing or legalizing cannabis for recreational use. So much of the work of the second rapid synthesis has already been discussed, but I'll quickly go over a few key findings and then close with a quick update on the Canadian policy context. So my own key findings that kind of complement Jason's, I think, was one that we found in our rapid synthesis that in jurisdictions that have pursued decriminalization or legalization, there tends to be a decline in the perception of harm of cannabis. We also found mixed evidence, as Jason already mentioned, about the prevalence of use, with the trend generally being, or the long-term trend at least, being towards having no increase in use. However, causal effects of this haven't been established. Also mentioned in the presentation, there does seem to be some relationship between ease of access and age rather than the methods of legalization or regulation as a whole. Both rapid responses found that legalizing marijuana was associated with increases in the use of health resources for marijuana-related incidents, accidents, and injuries. So this included calls made to poison control centers, ER admissions due to accidental ingestions, and increases in traffic fatalities. However, that point was also mentioned by Jason, that it was unable to determine whether individuals who had been using cannabis were at fault. It should also be mentioned, though, that the baseline rates of these prior to legalization were quite low, and so any increase in that is somewhat expected. In terms of interventions to prevent or reduce or manage substance use at the population level, we found mixed results on the use of mass media campaigns, with those that were successful typically projecting a message of autonomy. These need to be carefully monitored, though, as there was some evidence to show that they actually increased drug use. We also found school-based interventions targeting general drug use were somewhat effective, with those providing multiple sessions as being more effective than one-off discussions. Interestingly, the federal government announced yesterday that $36.4 million over the next 5 years would be spent on a campaign to educate Canadians about the health and safety of cannabis use. Details for the spending plan of this money is still to come, but part of it will be spent on helping Canadians understand the implications for their new laws in each of the provinces. So, as was previously mentioned, as part of the second rapid synthesis, we undertook a jurisdictional scan, which looked at other major jurisdictions that have legalized and decriminalized marijuana, with Uruguay as well as several U.S. states that are either about to legalize or had legalized in the previous few years. And we looked at how to see how they had approached the regulation, distribution, role of the physician, and insurance funding in each of these jurisdictions. Generally, we found that the legalized Generally, jurisdictions that have legalized cannabis permit the purchase and possession of about 1 ounce or 28 grams to be carried by adults with different age variations across states. Often it's age 21 in the U.S. Jurisdictions are mixed on whether they allow for home growth. Governments have generally taken a large role in licensing growers, distributors, and retailers, as well as applying taxes for the distribution and purchase of products. As Jason mentioned, there's quite a lot of money there to be reaped, as seen with the California case of really taxing at quite a high percent. And Canada is no different. We've now seen 2 provinces come out with their proposed guidelines on marijuana use. Both provinces are using the same age of consumption of alcohol and tobacco, which is following a similar lines as states in the U.S. who use 21 as their baseline. Alberta has specified the amount that the individual can possess at 30 grams, which is about 1 ounce, and 4 plants inside someone's home. It's my understanding that Ontario hasn't yet come out with this amount yet, but I could be wrong. The federal government is taking on the role of licensing producers to meet quality and safety standards, but is leaving it up to the provinces to regulate retail outlets, which Ontario has decided will be comprised of dedicated LCBO stores, and this has not yet been figured out for Alberta. So Steve, I'll turn it back to you.
Great. Thanks, Kerry and Jason again. So we have a couple of questions that have already come through. If anybody else has questions that come up as we go through this, please use the chat box to ask them, and then we'll answer them during our Q&A session here. So the first question is, are there any high-risk thresholds of cannabis consumption that can be recommended not to surpass as there exists for low-risk alcohol consumption guidelines? Jason, do you want to answer that?
Yeah, well, I wish we had an answer to it. So there has not been any thresholds proposed that I'm aware of. If you look at the literature where they use cannabis for therapeutic purposes, and a lot of that literature is focused on pain, the daily consumption tends to be about a gram per day at most. Some studies have used upwards of maybe 3 grams. There is evidence to suggest that as you increase your use, you are at higher risk for increased adverse events. There was the one systematic review that looked at the risk of early onset psychosis. They did show a dose-response effect, but it tended to be somewhat crude and difficult to sort of place an exact figure on when that risk threshold becomes unacceptable. So at least to my limited knowledge in this area, there is a sense that using more is likely to be associated with worse adverse events, but there is not a clear idea at this point on what that threshold should be. I do know that Veterans Affairs, for example, they used to authorize for their for veterans associated with their group that they could be authorized to have, I think it was up to 10 grams per day, and they've reduced that now to, I believe, much closer to 7. So people are trying to keep the amount lower, but as far as I know, we don't have good evidence to say here is the number at which people should stay below in order to see greater benefit than harm.
Great, thanks, Jason. And I know you touched a bit on the issue of research already, but we have another question asking, how do you see legalization of non-medical cannabis to impact medical cannabis research?
Main agents that we look to in terms of an effect in cannabis, and again, there are hundreds of cannabinoids, and we don't fully understand really what they all do, but the 2 major components that there's been a focus on has been THC, which also produces the euphoric effects responsible for the feeling of getting high, and CBD, which is thought to have fairly potent anti-inflammatory action, but does not produce any feelings of euphoria. Now, these 2 components compete. So if you create a plant that has high levels of THC, it will, by definition, have very low levels of CBD. And there does appear to be an interest, at least from the purpose of medicinal cannabis, in producing strains and products that have high levels of CBD. The recreational cannabis, I think it's fair to say, will have a very different focus. They will probably look at producing strains that have very high levels of THC. And so I think you're going to see the cannabis, the sort of market for it almost diverge in terms of one type of, strains that are focused more on recreation and another type that's focused more on medicinal. So the issue is always, once you legalize something, does it really sort of end up cutting into the medicinal side, that it becomes very difficult to do a lot of study. But I think in this case, because of the important differences in how plants can be cultivated, even after legalization occurs, there's going to be a lot of interest in continuing to do work on the medicinal application of cannabis. And of course, we'll have to see to what degree users end up favoring, high THC strains over high CBD strains if they're still attempting to look at substitution for prescription medication or to find therapeutic relief from various conditions they might be suffering. So there's some uncertainty, but I think there's going to be room for work in both to continue for quite some time.
Great. And then we have another question about whether anyone has looked at research around marijuana and driving impairments or motor vehicle accidents and dose relationships.
There has been a number of reviews on that topic. One of the better ones that I'm aware of came out in the British Medical Journal, but quite a while ago now, probably around 10 years ago. So it probably deserves to be updated. There have been some more recent ones, but I don't think they have the same level of rigor. From my recollection of the studies, they have shown an association between intake of cannabis and a higher risk of motor vehicle accidents, but I'm unable to say if they determined a specific threshold at which that risk became important. This sort of highlights one of the challenges that's really going to be faced, I think, by regulators in terms of if this becomes a legal recreational substance and we know that it has an impact in terms of impairing ability to drive, how is law enforcement going to test when someone exceeds a certain limit, when they're sufficiently impaired that they should not be driving, such as they have currently with alcohol, where we have established a blood alcohol level that we feel is excessive for someone to be able to safely operate a motor vehicle. I am aware that there's a number of groups currently working on this issue and trying to come up with both machines that will do testing and some sort of guidance around a threshold, but at this time I can't tell you what that threshold is.
Great. Okay, so we have a couple more questions that have come through here. So this one is a bit longer, so bear with me. It's should we be concerned about patients substituting their prescription medications for the use of cannabis? Prescription medication dosage is regulated and monitored by family physicians. Is the production of medical cannabis at a point where we can regulate THC cannabinoid consumption? My concern is that self-substitution could lead to misuse or overuse, which can impact other aspects of one's life.
It's a great point, and I fully agree with the concerns. I mean, we're getting into an area where we really have people substituting a known and quantified product for a product that is largely unknown, completely variable. We don't know what components are providing an effect. We don't know what the trade-offs are between harms and benefits. And there's been at least some qualitative studies that suggest there might be an effect beyond the sort of properties of cannabis itself that users might like, and then you use that as a motivation to substitute. And this is the control that it gives them over their condition. There has been some qualitative research done where they talk to patients, for example, with chronic pain and say, why have you gravitated to cannabis over prescription medication? And some of them will talk about this concept that they feel more in charge. They feel able to take what they feel, what they need, to try different types of consumption methods, different types of products. And it's this empowerment, this feeling of control they have over a chronic, incurable condition in most cases, that may also be quite appealing. So I do think that we have to be concerned. I think it's important to recognize that substitution does appear to be going on, but we don't know if that's for the better or for the worse. And it remains an important area of study that we need to undertake and really work on educating patients to understand reasons why they're substituting and to make sure that what they are doing at least has oversight by their healthcare profession to ensure that it's done in as safe a manner as possible.
Great. So we have a quick follow-up question in terms of the medical research question that was asked before. So the statement is that I'm concerned with legalization. There will be an overemphasis on the social harms of legalization and less emphasis in funding. We are already seeing CIHR develop funding programs focused solely on non-medical cannabis. Could legalization contribute to the continued stigmatization of medical cannabis?
Well, again, one of the projects that I mentioned that we're undertaking is to sort of talk to patients about, how do they feel about the use of medicinal cannabis to manage their pain, for example. One of the projects I didn't put up that we plan on undertaking is a qualitative study specifically focused on the stigma that individuals that have begun using medicinal cannabis are experiencing. We know, for example, around high-dose opioids for chronic pain, a lot of long-term users do describe stigma associated with that, being treated as if they're a drug addict, having difficulty when they go to the emergency department, when people see the doses that they're on, having difficulty finding a new physician who will continue the prescribing that their previous physician had. I think all these issues are likely to come up with medicinal cannabis use as well, and we do need to understand them better. Now, as you did hear from the rapid synthesis that was undertaken, once a product becomes legal, some of the stigma around medicinal use starts to reduce. How much will it reduce? We don't know. Will it change based on how people are consuming it? If it's, an oil in a capsule, does that become more acceptable than lighting up a joint, for example? So I do think it's an important issue. If we do determine that medicinal cannabis has an important role to play in providing relief for at least certain medical conditions, it's important that we address barriers to use, which would include inappropriate stigmatization of users.
Thank you. So we have a couple of, or another question here just about, I guess, focus more on the U.S. So first of all, a statement saying that U.S. states that have legalized recreational cannabis allows purchase as of 21. And then the U.S. states that have legalized recreational pot have allowed it as of 21 years old to align with ages of purchase of alcohol and tobacco. Would it be beneficial or feasible to increase the age of purchase of alcohol, tobacco, and pot in Canada to 21 years old?
Yeah, this is a question I'm sure that has been intensely debated when the policy was formulated. I also know that the Canadian Psychiatric Association has put out a statement cautioning amongst use for individuals between the ages of 18 and 21 in particular, because of the evidence that we have showing an association with increased risk of psychosis. The challenge is right now, if you look at the illicit market in Canada, and again, as of 2013, we were the #1 consumer of cannabis amongst all other developed countries. I don't know of any reason to doubt that we've lost our current place in the hierarchy, but a great deal of that use is already occurring amongst individuals aged 18 to 21. So if you're going to bring a product into the legal arena, but you're going to continue to prohibit it from one of the largest groups of illicit users, the policy is going to struggle to reach those that you are trying to bring into safer patterns of use with regulated product. So there's a real challenge here in terms of understanding if we already are going to have sizable numbers of emerging youth using it illicitly. Are we better off to continue to pursue a policy of prohibition where they will simply find the product as they will in an unregulated way without any quality control or safety measures? Or should the policy expand to include that group even though we know they may be at higher risk for certain harms, but on the basis that overall we may be able to substantially reduce their risk of other harms? So I'm sure this was a tension that was discussed at length when policies were being derived, and there certainly may be a need to revisit it, but it remains a complex issue.
To add to that a little bit, I think two somewhat important points. One of them is that the age differs across provinces based on where typically based, or at least in the case of Alberta and Ontario, it's aligned with alcohol and tobacco use. So in Ontario, it's age 19. In Alberta, they're suggesting 18 because that's the current age of allowance there. I think knowing that the average entry point of first use for cannabis the average age is 18 in Canada, and there's very few individuals who first use after the age of 25, that I agree very much with what Jason's saying, and that it may kind of more continue to drive into the black market more than trying to provide helpful policies. The other thing to consider, the second piece of that question, was about whether you could change the purchase age for alcohol and tobacco. And I think that, again, that's something that's provincial to provincial, but province to province and territorial. But I think the bigger problem there is you're going to have an enormous pushback of trying to change that age, and it's a challenge that when you're already kind of going down a policy route that's somewhat difficult, trying to take that on is likely another difficult challenge.
Great. Thanks, Kerry and Jason. So we have a couple of questions here that are similar, so I'm going to just sort of string them together. So the first one is, should we be considering a qualification for folks at the dispensary level? And then the next few relate to more, I guess, about the quality of products. So do we have the regulatory institutions to enable us to empower consumers to understand the dosage and the variety of strains, edible versus hash oil, etc.? Will the government do chemical qualitative analysis from the producers of the cannabis products? And lastly, is there any concerns that cannabis could be laced similar to opioids?
So, moving on. Sorry. So, from Steve, you may have to repeat parts of that question at some point. But in terms of the first piece of qualifications of individuals who work at dispensaries, currently the guidelines in Alberta are suggesting specific training for individuals who are going to work at the dispensaries. This hasn't been specified in Ontario, and as mentioned earlier, we don't know about the rest of the provinces and territories across the country. So that, I think, is something that province at least is planning on rolling out, is an interesting model. In terms of the distribution and growing of cannabis, it currently will be regulated by the Government of Canada in terms of that they're only going to license a certain number of growers and a certain number of distributors, all of which will have to meet quality and safety standards. So lacing on that end that's kind of the prevention mechanism for the legal route. Of course, when you're looking at black market cannabis, it's theoretically possible.
Yeah, absolutely. And I'd echo the point that it would be nice to see some regulation around mandatory education that should be provided as we learn more about the benefits and harms of cannabis in general. I should also state that we're really in, to some degree, uncharted territory here. I mean, we're almost back to medieval medicine. This is not a carefully created, isolated product as most medications are. This is a plant. This has literally hundreds of components in it, which we don't fully understand the mechanisms, I think, of any of them yet, and they may interact with people differently. We certainly have preliminary evidence suggesting differences based on gender, differences based on age. differences based on genetic predisposition to certain disorders. So it's a bit of a wild west, and again, we need to sort of learn as much as we can so that we can provide good information to consumers as well to distributors to do whatever we can to ensure optimal safety around dispensing and use of this product. But we really have quite a ways to go before we have the kind of information that we'd like to have.
Great, that's excellent. Thanks very much. I don't see any other questions immediately coming through, but that's been a very insightful presentation, and certainly a lot of good discussion on that as well. Just as a bit of a side note, I saw something in the news just from yesterday that apparently Ottawa has committed to spending over $36 million on over 5 years on a campaign about legalized pot and some of the challenges around that. So certainly something where there's going to be continued investment and continued work for sure, and hopefully some of the work that Jason is doing with his group and some of the work that we've done to help him as well will hopefully help to provide an evidence-informed discussion around this. So I don't see any other questions coming in, so I'd just like to say thank you to Jason and Kerry for their time today and for joining us and really sharing some very valuable insights on this topic.